So welcome. This is our second webinar in our two-webinar series on culturally appropriate engagement and service delivery with Latinos. As you recall, we're using Puerto Ricans as a case study. We're looking at issues of cultural competence and how cultural competence can really help improve engagement and retention. And so for this next sort of part of our webinar series, we're going to be reviewing some important concepts related to HIV/AIDS among Latinos, and also we're going to look more formally at the connected epidemics of incarceration and HIV among Latinos. Again, I'm Vincent Guillermo Ramos. I'm a faculty member at New York University. I'm primarily, my sort of academic home is the Silver School of Social Work, but I'm also professor of public health and nursing here at NYU. I direct and I founded the Center for Latino Adolescent and Family Health, CLAF, which is a center that specifically addresses issues of Latinos and the health and well-being of Latinos in the US. And also in parts of the Spanish-speaking Caribbean and Latin America. I am the director of a pilot and mentoring corps that is a NIDA P30 funded center that's specifically designed to address the HIV epidemic among substance users. It's called CEDAR. And then just to sort of make what I'm talking about today a little bit more applied and more practical and more sort of a grounding place in terms of how I think about my work with individuals living with HIV. I'm also a nurse practitioner responsible for caring for HIV-positive adolescents and adolescents at risk of acquiring HIV here in New York City at Montefiore Medical Center in the Bronx as part of the Adolescent AIDS program. A couple of acknowledgements, some thank yous. I want to acknowledge the lead organization for the curriculum, New York City Health and Hospitals, in particular the Correctional Health Services. There's a really terrific team there that is headed by Allison Jordan, and also her team that is really responsible for the creation of the grant and for the execution and the whole idea of how this curriculum came to be, and sort of the basis for how we developed this really comes from the team that is housed at Rikers Island and is part of New York City Health and Hospitals. I want to acknowledge Janet Orsima, Dr. Janet Orsima, who is responsible for a lot of the work that's being presented here today. She's one of the primary architects, in particular as it relates to evaluation and thinking through some of the content and logic and flow of the curriculum. And I also want to say thank you to the funder, which is the U.S. Department of Health and Human Services, and through the Special SPINS initiative, which is the Special Projects of National Significance. And the particular mechanism that is funding this webinar is Culturally Appropriate Interventions of Outreach, Access and Retention Among Latino Populations. I mentioned earlier that the grant was actually received by New York City Health and Hospitals in the Rikers Island team, Allison and her team. And for our purposes, we're focused on Puerto Ricans, but a lot of the content is actually useful for Latino populations in addition to Puerto Ricans. And there will be times when I reference Latinos and times when I talk specifically about Puerto Ricans. I want all of us to have as much sort of use of the curriculum as possible. And so please think about your own local Latino communities and how the kinds of ideas that I'm presenting are useful to the overall US Latino population. Here's our agenda. We're going to do some key concepts like we did in webinar 1. We're going to look at some important demographic and sort of core knowledge and core sort of information about the US Latino population in our country. Then we're going to jump right into module 2 and 3. And module 2 is really looking at an overview of HIV/AIDS among Latinos, and then also what's called the HIV Care Continuum. And so we'll look at sort of each step of that continuum and how Latinos are doing. And then we're going to tie that formally to the interconnected epidemic of incarceration and HIV/AIDS among Latinos. And so we'll look at HIV/AIDS and incarceration, and we'll wrap up with the case application that really will pull together module 1, module 2, and module 3. And we'll apply this to the case example of Hector, and hopefully it'll be an opportunity to illustrate all the things that we've been talking about across the entire curriculum. So some key concepts. So the first thing I want to highlight is that here's sort of a pie chart that really shows the Latino US population in the US. And what you can see here is that there are approximately 58 million Latinos living in the US, and this is an estimate, and that Latinos represent about a fifth of the population. So to be exact, 17%. I think it's important to acknowledge, and you can see it in the pie chart, that Latinos are the largest ethnic minority racial group in the country. And I think even more important, if you think about the Latino community, which you can see here, is that overwhelmingly you can't talk about being Latino without understanding that the bulk of Latinos in the US are Mexican, and then certainly Puerto Ricans and other Latino groups represent a significant proportion. So you can see here in red that 2/3 of Latinos are Mexican, and then almost a quarter of Latinos are Puerto Rican, Cuban, Dominican, and from El Salvador. And so if you take those groups together, then they represent sort of close to a quarter. This is really, I think, very important for the United States. And so you can see here, I mentioned that right now, Latinos are the largest ethnic racial minority group in the country. But you can see that as of 2015, the estimate that was that Latinos would be roughly 18%. They're about 17%. So a little bit under what the estimate was. But you can see the projections going out, 2020, 2030, 2040, up to 2060. And you can see that by 2060, 1 in 3 people in the United States is projected to be Latino, 1 in 3. And I think what's really interesting about that is that if you want to get a sense of what that's like, for those of us that live here in New York City, the Latino community is already 1 in 3. And so if you want to sort of understand what the US will look like in the future, then you can just look at New York City now. 1 in 3 people in New York City are Latino. It's also important to keep in mind that the Latino community is geographically concentrated in 5 states. And so you can see that California has the largest number of Latinos, representing roughly 27% of the Latino overall US population, Texas, Florida, New York, and Illinois. And these are what we call historical traditional places where Latinos have settled. And again, these places still lead in terms of the concentration and the density of Latinos in our country. However, and this is actually very, very important, particularly for folks that are residing outside of those 5 states, you can see that there's fast growth of the Latino population across the US. If you look at the map, large segments of the United States actually have tremendous growth in the Latino population. Latinos are moving to places where there are jobs, and they're moving away from places where there is sort of less opportunity for employment, or maybe the conditions where they had been residing are not conducive to their being able to establish themselves and settle there. But for the most part, particularly sort of in the Southeast, certainly in the Southwest, in the Northwest, actually sort of both coasts and the South broadly, you can see that there is significant sort of growth for the Latino community, and that it's actually quite rapid. There's a lot of debate. There's been sort of a lot of talk about what's really driving this, and whether or not it's migration or it's fertility or some combination. And so I want to really address this from a science-based perspective. So if you look at sort of our most recent data, you can see here that the Latino population grew about 2%, while the overall population grew by 0.7%. So Latino population growth is sort of more rapid, it's much larger than the overall population growth. Latinos accounted for more than 50% of the population change in the United States. And so there was an increase of approximately 1.13 million Latinos. Now, what's interesting about that population growth, if you look here, migration is roughly 290,000 is the addition of individuals who are Latino to our country's population, that are because of migration. You can see that there were roughly, 183,000 deaths, but really what's driving the boom in the Latino population growth is the over 1 million births. And so fertility is really what's driving the growth of Latinos in our country. And I think it's worth mentioning that these Latinos that are being born in the US, these are US citizens. And if you think about what I said earlier about the estimates of what the Latino community will look like in 2060, most of what's driving that is actually fertility. You can see here that in terms of drivers. At one time in the 1970s, US births and migration were equal. In the 1980s, migration was actually greater than US births in terms of the increases in the Latino community. In the 90s, the same pattern was happening. Migration was higher than US births. But in the 2000s, there was a dramatic shift. So you can see here that in the 2000s that US births actually bypassed migration. And certainly from 2010 to 2015, you can see there's been significant reduction in immigration as well as fertility, but still fertility accounts for much more of the increase in the Latino community relative to migration. And so, this is a pretty interesting slide. It kind of depicts what I just said. It means that overwhelmingly the majority of Latinos are born in the United States, and they're actually US citizens and are likely to be here and reside in this country. One of the things that's very interesting about Latinos as a whole is that our population pyramid, which is what you see on the slide, we're pretty young. And so if you look at the overall sort of white population pyramid, you notice that at the top, which represents sort of older individuals, 45 to 49, 50 to 54, and then folks that are older than that, it's pretty wide at the highest part of the white pyramid. It's sort of, kind of wide in that sort of 45 to 74 category. But if you look at the Latino pyramid, you notice in that same sort of place, there are some people there, but the widest part is actually down at the bottom. And so if you look to 25 and under, about half of all Latinos, about half are 25 and under. And so, if you look at 25 and under for whites, it's not the case that half are under 25. There's actually more people that are sort of older and then are in that sort of 40 to 70 range. And so, why is this important? This is important because Latinos are a young population. And so you can see the median age of the white population is 38. The median age of the Latino population is 28. If you look at Latino subgroups, the largest Latino subgroup, which is Mexican, is their sort of median age is 26, whereas Puerto Ricans are 29, Guatemalans are 28, and Cubans are 40. With the exception of the Cubans, the other Latino groups are, pretty young. Latinos as a whole are the youngest and the largest ethnic racial minority group in the country, and certainly Mexicans account for the largest proportion and represent sort of the youngest in terms of all the Latino groups. When we think about important health issues that are facing Latinos, if we look at the sort of the Health and Human Services, the Office of Minority Health, and also the Centers for Disease Control Prevention, you can see that these are the issues that Latinos are facing in terms of their health. And so I won't review all of these, but I do want to highlight a couple. So certainly HIV/AIDS, which is the focus of our curriculum, but there are also things that are associated or are comorbidities with HIV/AIDS. And so we would want to think about mental health disorders. We do want to think about sort of unplanned or premature pregnancies that occur during adolescence. We would want to think about cardiovascular disease and diabetes and cancers. Those are things that can also sort of be comorbid or somehow have a relationship with HIV and AIDS, and we're going to talk more about that. So when we think about the socioeconomic status of Latinos in the US, we talked about them sort of as a community that we're concentrated in certain geographic areas. We have rapid growth, we're young, we're predominantly Mexican. We're also have a greater likelihood, about 1 in 5, to actually be classified as being below the poverty level. And so, 19% of Latinos are below the poverty level. This sort of figure is not saying anything about people who are slightly above the poverty level, and it's not saying anything about people who are transitory and who actually might experience a loss of a job, an additional expense, a missed check. They might have gotten sick and been out and lost compensation for those days. Those kinds of events can move Latinos who are currently not below the poverty level to actually temporarily be impacted and move below the poverty level. So why I'm sharing this is that roughly 1 in 5 are below the poverty level. But if we were to look at sort of near poor and transitory poor, we would find that it's a much larger segment of the Latino community. You can see here the median income for Latinos is roughly $48,000, while the median income for non-Latino whites is $65,000. In terms of barriers to health care, access for Latinos, certainly lack of health insurance, and so having sort of a lack of a steady provider, having what we call episodic care that is often delivered within the context of an acute care setting, like in sort of an emergency room or an urgent care facility, versus primary care. Those are things that have been sort of associated with Latino experience. Immigration status not being documented, not having sort of ID or feeling concerns about immigration can prevent you from accessing care. Language barriers, not having providers or organizations be able to communicate with you. Cultural bias and stereotyping, and so feeling distrust of healthcare providers, feeling distrust of healthcare systems, not feeling welcome, not feeling warmth, not feeling that there's a personalism, a respect, a harmony. A lot of what we talked about earlier, that those things aren't reflected in the way that care is delivered. And so Latinos may feel that that lack of attention to those aspects of care delivery, that those are barriers to them being able to maintain their health and well-being. Lack of access to information. The information may not be distributed or targeted to Latinos, or it may not be available in sort of formats, whether it be Spanish or in sort of high health literate documents that allow Latinos of low literacy to be able to understand and to be able to incorporate. You can see here that individuals who don't have health insurance, you can see Latino, Hispanic, represents the largest segment without health insurance. And so, again, this only reinforces that where there's no coverage, it's going to be hard, particularly within the context of economic barriers, sort of language barriers, immigration status. It's going to be hard to have a routine source of care, including HIV primary care. Some takeaway points. Latinos are the largest ethnic minority group in the United States. Sometimes that, I think, gets forgotten by many sort of individuals. That growth in the Latino community in the foreseeable future will continue. It's primarily due to fertility and births. These are U.S. citizens. It's not because of migration. And so issues regarding migration, that's an interesting sort of place that we find ourselves at this moment in time, especially because we're building or there are plans to build a wall between sort of Mexico and the United States. There are just as many people leaving the U.S. and returning to Latin America as entering. And so, it's interesting that a lot of our resources and our sort of funding are going to go to building the wall, when in fact, the vast majority of Latinos are actually born right in this country. Latinos are young, they're the youngest, not only the largest, but the youngest, and that Latinos as a whole face some unique socioeconomic and also some health care access, challenges. I want to talk about one of the health conditions that is the focus of our curriculum, which is HIV/AIDS. I want to provide a bit of an overview and talk about some things that I think are important to mention that might put some of the curriculum into context. And so the first, President Obama, he established in 2010 the National HIV/AIDS Strategy. It's interesting because at the time when President Obama established the strategy and it was released in July of 2010, we were roughly 3 decades into the U.S. HIV/AIDS epidemic. Never before in our country's history did we have a national strategy, yet as a country we required any country in the world that was receiving PEPFAR money, which is the largest gift for any global health issue. It's specifically for HIV/AIDS in countries that are most impacted by the HIV/AIDS epidemic. We required each of those countries to have a national strategy, and yet the U.S. did not have a strategy. President Obama should be credited for assembling a team to actually serve in the Office of AIDS at the White House, and they came up with 3 main objectives. The first was to reduce the number of people who become infected with HIV. We've made great progress in our country, but we still have too many people becoming HIV positive each year, and the incidence sort of rate has settled at an alarmingly high number despite there being much progress. We also wanted to increase access to care and optimize health outcomes for people living with HIV. We know that treatment is prevention. We know that we have a huge effort, a huge initiative called U equals U. Undetectable means untransmissible. And so people who are HIV positive, if they're in care, they're retained in care, they're virally suppressed, it is impossible for them to actually transmit HIV to others. Viral suppression means that they're unable to transmit HIV to others. Not only is it, from a public health point of view, a really smart national strategy, it's also important for reducing morbidity and mortality. There's no reason why an HIV positive person who is receiving care in a developed country should not have sort of a life expectancy, or certainly the potential of having a normal life expectancy. And that's dramatically different than what we would have said early on in the epidemic. And also the national strategy as developed in 2010 was to reduce disparities. It's still the case that there are disproportionate numbers of people of color who are experiencing sort of HIV infection. They're becoming infected at alarmingly high rates. Latinos and also African Americans. We also know that oftentimes in certain communities, certain racial ethnic minority groups, the onset of an HIV diagnosis or the sort of awareness that one is living with HIV is often co-occurring with an AIDS diagnosis, which means that they are being identified too late in their HIV disease. They're not being identified early on when their immune systems haven't been compromised, and they could actually benefit most from antiretroviral treatment. And we also know that there are disparities in terms of our care cascade and how well people do once they are identified in terms of being linked, being retained, being offered antiretroviral treatment, and becoming virally suppressed not only once, but maintaining a sustained viral suppression. President Obama updated the care cascade in 2015, 5 years later, and this was the national strategy update. And the 3 goals or objectives are still there, but there was a 4th one added. There was recognition that there needed to be more coordinated national response to the HIV/AIDS epidemic, and that much of the disparities that we face as a country are tied to social determinants of health. And that means that the education department, the housing department, the labor department, all the different aspects of our federal sort of agency or agencies and the sort of federal government and all of the different aspects or segments of our society, if we were going to be successful at eliminating HIV/AIDS in our country, that it was going to require a more coordinated national response. In so the focus in 2018 and so 2017, there's been sort of a new sort of focus, which is the Trump administration's increased emphasis on the U.S. opioid epidemic. And so we know that there are more than 2 million Americans that have an addiction to prescription or illicit opioids. And we know that there are 300,000 overdose deaths involving opioids that have occurred since 2000. And you can see here on the slide that 175 Americans died from a drug overdose sort of per day. And so that was in 2016. If you look at the data, that roughly 175 Americans died from a drug overdose. And so again, the reason why I mention this is because I think the opioid epidemic certainly is a real potential threat to our national strategy and all the progress that we've made. We know that people who become sort of opioid users and become addicted to opioids may at some point transition to heroin, and that there is definitely a sort of trajectory from sort of prescription opioids to injection opioids and injection heroin use. There are roughly 1.1 million people in the United States who are currently living with HIV. And so most people who are living with HIV in our country actually know that they're living with HIV. That's a great thing. There was a time when that was not true, and when the vast majority of people living with HIV were unaware of their status. Most people today in 2018 know that if they're HIV positive, they have been identified. It's still the case that 1 in 7 are unaware of their infection. And I want to highlight, because it's worth mentioning, particularly because Latinos are so many within the Latino community are actually young. We know that for young people, that the vast majority of young people who are living with HIV are actually unaware of their HIV status. And so it's close to 50%. That's actually a more accurate number. It's about 44-45% of HIV positive youth are unaware that they're HIV positive. And so even though most of the overall population of people living with HIV have been identified, we still know we have significant work to do among young people. And because Latinos are overwhelmingly young, it's also fair to say that we need to think about identifying young people who are Latino living with HIV. I mentioned that we've had great progress in terms of reducing incidents or new cases in our country, but it's still the case that roughly 40,000, you can see here on the slide, 38,500 people became newly infected in 2015. These are based on data that were released in 2017, but the data comes from 2015, and so that number has been fairly stable, and it's too many. There's still close to 40,000 people who become newly infected with HIV in our country each year. You can see here that in terms of our epidemic, we've made great progress. Overall, new diagnoses have gone down, and so there's been a 5% decrease in HIV diagnoses. That's really terrific, and that shows that a lot of our work in terms of treatment and also prevention has paid off. It's also true that there's been a 4% increase among Latinos, and that increase has happened not just as a standalone event, but it's happened during a time when there's been a reduction in overall diagnoses. And so it should make us more concerned about what is happening among Latinos in our country, that while the overall is going down, there's an increase in Latinos who are being diagnosed with having HIV. A state of emergency, an area that should be of great concern, is that there's been sort of a 22% increase among Latino gay and bisexual men, particularly young men in the same period. And so not only do we see overall improvements in new diagnoses, we see some increases among Latinos within the context of overall improvement, and we definitely see a dramatic increase among new diagnoses among young Latino gay and bisexual men. It's also true that there have been some areas of our country, some geographic clusters that have been what we call high transmission areas. And those high transmission areas are places in our country where there has been much more likelihood of a new HIV infection occurring. Many of those high transmission clusters or geographic areas are actually in places where there's a high concentration of Latinos. And so, again, really important, Latinos are young, Latinos are being disproportionately impacted by new diagnoses, and certainly within the 13 to 29 age group among Latino gay and bisexual men, there's been a pretty alarming increase in terms of new diagnoses. If you look at the overall estimated HIV incidence in the US, it fell between 2010 and 2015 by 8%. It was stable among all gay and bisexual men. However, it increased 22% among Latino gay and bisexual men in the same period. So again, the same sort of core argument that we see progress overall, we see that even in cases where we haven't seen reductions, we've seen things becoming stable, but we see increases among Latinos. And so really important to keep this in mind as we think about what I would call kind of a state of emergency. That's actually been language that I borrow from some of my colleagues at the Latino Commission on AIDS, but Latinos are often overlooked in terms of the HIV/AIDS epidemic in our country. And I think that we need to think about what is happening with Latinos in particular geographic areas and in certain age groups with certain risk exposures that is lending to this increase in incidence and new diagnoses that we're seeing. So let's look at the 10 states, the largest Latino populations. You can see that on the right-hand side of the slide. You can see, the usual culprits, the 5 that I mentioned, plus a couple of others. And also look at the rates of HIV diagnoses. What should stand out is sort of the darker green is where the rate is higher, but there's an overlap. The darker green tends to overlap with the states with the largest Latino population. So Latinos primarily live in states with some of the highest rates of new HIV infections. If you look here, these are the number of new diagnoses among Latinos. And the same basic pattern is emerging. You can see that the states that have high concentrations of Latino populations are also the states that have the highest number of new diagnoses among Latinos. You can see here racial and ethnic disparities in HIV/AIDS, and so certainly it would be irresponsible of me not to mention the African American or Black community disproportionately impacted by HIV/AIDS, but Latinos are also disproportionately impacted, and much more so than other groups. And you can see here that the new HIV diagnoses decreased among Black and white populations, but it increased among Latinos in the period 2011 to 2015. You can see here that the highest number of new diagnoses was among the 20 to 29-year-olds, so again highlighting youth and the vulnerability of youth, keeping in mind the large concentration of young people that are a part of the Latino community. And so here are some take-home points. Youth represent a significant proportion of new HIV infections in the US. Latinos are particularly at risk for HIV. So many Latinos are young, and disparities in HIV diagnoses are clustered or concentrated in geographic areas with high concentrations of Latinos. I want to look at the care continuum, and the care continuum is a way of thinking about sort of how we're doing in terms of our primary care delivery to individuals living with HIV/AIDS in our country. So you can see here that there are 1.1 million people who are living with HIV/AIDS in the US. That's an estimate. About 85% of those individuals know that they actually have HIV. And so 15% of HIV positive people don't know that they're living with HIV, but the vast majority have been diagnosed. We've made a lot of progress here. We should be proud of this. There was a time when few people knew that they were diagnosed, but now the vast majority know. Where things get a little bit trickier is that if you look at receiving care, retained in care, and virally suppressed, you can see that the numbers drop off dramatically, that it's 62% that are receiving care, 48% that are retained in care, and 49% that are virally suppressed. There are some different numbers that are reported in the literature, and so there could be some debate about how we're doing as a country, with some estimates and some indicators suggesting that we're doing better than what I've presented here. But I wanted to present this image that I've taken from the CDC, from data that was published in 2017, and I'm going to use this as a common reference to talk about what I see as being additional work that we need. We need to continue to identify people living with HIV, particularly among young people. What's not reflected here is the 44% of HIV positive youth that are unaware of their HIV status and yet are infected. And then across all of people living with HIV, we need to link them to care, get them retained in care, and get them virally suppressed at much higher rates. And so we want it to be that the vast majority of people living with HIV are in fact virally suppressed and preserving their health and unable to transmit to others. You can look here, there's roughly 252,000 Latinos living with HIV in the country. You can see the care continuum again for Latinos, 83% identified, 48% virally suppressed, not that different than the overall care cascade. You can see here African Americans, Latinos, and whites. And you can see that, generally speaking, across the groups, you can see the total numbers. You can also see how people are doing. Whites doing the best, 57% virally suppressed, Latinos 48%, and also, African Americans 43%. And so there's more work that needs to happen among Black and Latino communities in terms of linkage, receiving care, retention in care, and achieving viral suppression, particularly as it relates to sustained viral suppression, right? So, a moment of self-reflection. What impact can culturally competent care have on the HIV care continuum? And how do you envision your role in addressing these HIV sort of service delivery challenges? So I'm going to continue by actually covering this final module where we'll be looking at the sort of interconnected epidemics of HIV/AIDS and incarceration. And we're also going to be taking everything that we've done in webinar 1 and 2 and applying it to the case study of Hector. And so I want to start off by just covering this topic and formally linking HIV/AIDS and incarceration. And so these are some facts that I think are really important for providers, all different kinds of providers, to be aware of. And so, Latinos are overrepresented in the U.S. Justice system. Nationally, the incarceration rate among Latinos is nearly twice as high as among whites. And so you can see here on the left-hand side that in federal and state prisons in 2016, there were approximately 339,000 Latinos that were incarcerated. These represent large ethnic racial disparities among justice-involved individuals in the United States. And unfortunately, if we look at projections of what's going to happen in the future, that basic pattern is likely to continue. So in the continental United States, each year, 1 in 7 people with HIV will pass through the correction system. And that's something that I don't want to have lost. Many of you may be thinking, well, why are they focusing on HIV/AIDS and the interconnected epidemics? Well, one of the main reasons is that oftentimes the correctional system is the first place where justice-involved persons are diagnosed with HIV. And so 1 in 7 people who are living with HIV will pass through the correction system. We also know that the vast majority of HIV-positive individuals acquire HIV before they enter the prison system. And so they didn't acquire HIV while they were in prison. They actually came into prison or jail and they were already HIV positive. If you look at the rate of diagnosed HIV infections, it was 4 times greater among incarcerated individuals than among the general public. And we also know that there are approximately 17,000 justice-involved individuals who are HIV positive, and that there are some geographic areas where there tends to be more justice-involved individuals living with HIV. And so you can look here that New York State, California, Florida, and Texas have among the highest numbers of HIV positive justice-involved individuals among all states in the continental US. And what's also interesting, and should be jumping out, if you look at New York, California, Florida, and Texas, these are also the geographic areas where we have high concentrations of Latinos. These are also the areas where there have been increases in terms of sort of new HIV diagnoses, particularly in the South. And so if you look at Texas and Florida, and so again, there's a lot of overlap between where Latinos are, where HIV is, and where there are large numbers of individuals who are HIV positive and justice involved. Given current incarceration rates, and this is something that's really, in my view, very distressing, and the growth of the continental U.S. Latino population, Latinos are at high risk of becoming the largest ethnic group among incarcerated individuals. And so right now, Latinos are the largest ethnic racial minority group in the country. We also have talked about some of the increases in HIV incidence among Latinos, particularly young Latinos. And so I want to highlight, because again, here's another example of how oftentimes when we think about HIV/AIDS and also incarceration, there's a tendency, and rightfully so, to focus on the African American or Black community. But I also want to spend this time and have an opportunity to really highlight sort of the state of affairs in the Latino community. And you can see here that given the increases in the Latino overall population, there's a large risk that Latinos will become the largest ethnic group among people who are incarcerated. By 2050, there's approximately sort of 130 million Latinos that will be residing in the continental US. And with those projections of the sort of exponential increases in Latinos, there are also projections that there'll be as many as 3 to 5 million of the overall Latino population that are incarcerated. Using New York City as a case example, here are data that come from Allison Jordan and her colleagues at Rikers. I mentioned earlier that Allison is one of the primary architects behind this initiative and the receipt of funding, as well as the ideas that are being presented here in the curriculum. And so I want to share some of her data. I borrowed this image from one of her articles, and you can see here that New York City remains the epicenter in our country of the HIV/AIDS epidemic. And you can see here that the number of new HIV diagnoses are reflected in sort of the shaded red areas. And as they get sort of darker in terms of being red, those represent sort of greater numbers of new HIV diagnoses. You can see that the dots, the number of people released, these are folks who are leaving Rikers Island, and depending upon the size of the dot, so the smaller dots mean fewer individuals, the larger dots mean larger number of individuals, represents sort of where they went back to. And so often it's where they come from prior to their incarceration, but these dots reflect also when the people were released, where they went back to. You can see that many of people turning to areas where there are sort of deep red colors, which represent sort of the greatest number of new HIV diagnoses. We also know that those red areas often have sort of a dot that tends to be one of the larger dots. And so lots of people released that are returning to geographic areas that are sort of concentrated with both HIV and also people who are being released and returning to those communities. This is something that is interesting. We talked about the HIV/AIDS care cascade in our country, but I want us to look now at the national cascade, and then also the cascade as it relates to the correction system. And so you can see here that if you just sit back and kind of look at what's being reflected, it has the national average upon entry into the correction system during incarceration and then after release. I want to highlight each step of the cascade: diagnosis, linkage, retention, initiation of antiretroviral treatment, and then viral suppression. And what's really interesting is the green sort of color represents during incarceration. I would have thought that people who were incarcerated actually would have had poorer outcomes in terms of their HIV care, sort of outcomes and their sort of clinical management of HIV disease. What was surprising to me when I saw these data from a paper that was a systematic review of a number of studies that was published in the American Journal of Public Health is that while people are actually incarcerated, they're doing better in terms of linkage to care, retention in care, initiation of ART, and also achieving viral suppression. And if you look at overwhelmingly what's happening when they're released from their jail or prison, they actually are doing worse across most of the steps of the care cascade after they are discharged from prison or jail. And so I want us to stop for a second and pause and to sort of ask ourselves, what do we think about that as providers who are caring for people living with HIV? It's a vulnerable period when people are coming from being incarcerated to being released, and upon their release, they're actually dropping out of the care cascade in much larger numbers. And so this is an area that we need to focus on, and this is why I'm hopeful some of what we've been talking about in terms of cultural competence as being one of the factors that is a barrier, that if we can enhance that through shared decision making, through DECIDE, through the cultural formulation, through attention to transnationalism, that these tools can serve as a way of helping people upon discharge from jail or prison to remain actively engaged in their HIV primary care. The correctional system is often a place where people are receiving their diagnosis. And so remember that they're not acquiring HIV overwhelmingly in jail or prison. They're actually coming in already infected and being identified. Incarcerated individuals have a tendency to have better HIV care continuum outcomes. And then, I've mentioned this already, but it's worth highlighting that the time when people are discharged, that represents a vulnerable period, and that after release from incarceration, that most of the individuals that we see in terms of our data are having a harder time sort of maintaining themselves involved in their HIV primary care. I want to take a little bit of time to take everything that we've done in webinar 1 and 2, and I'm hoping that we can apply it to a case study. This is an opportunity for us to think about a real person, and we're going to use the case of Hector. Hector is a Puerto Rican individual. I'll keep with our tradition of focusing on Puerto Ricans as one sort of exemplar of a Latino subgroup. I also want to remind everyone that it's not just about Puerto Ricans. It can be applied. Hector could be Mexican. He could be from the Dominican Republic, from El Salvador, from Guatemala, from any of the countries in the Spanish-speaking Caribbean or Latin America, or a Latino that is born in the United States. So I'm going to read the case, and then I want us to think about the case, and we're going to be looking at the cultural formulation, and for that matter, we're going to be looking at the 4 components of our cultural framework, or the 4 different sort of models or frameworks that we've talked about. And so just, I'm going to give folks a chance to kind of look at this, and I'll go through it slowly. I'm going to highlight a couple of things. So Hector is 30 years old, and so Hector is pretty young. He's male. He was born in Puerto Rico, and he came to New York City when he was 10 years old with his family. And so Hector's been living for the past 20 years in New York City. He has traveled back and forth between New York City and Puerto Rico, and he has completed actually parts of his middle school and high school in both New York City and Puerto Rico. And so he has an air bridge, and he's gone back and forth with a lot of fluidity. He is bilingual. He's fluent and has no language preference in either English or Spanish. He speaks both very well. And after he graduated from high school, he decided to look for a job in New York City and Puerto Rico. I think that he decided that instead of going to college, that he would work half of the year in each of the 2 locations, and that this would be a way for him to support his siblings. And if I remember correctly, Hector had some other family members as well that he was supporting in Puerto Rico, in addition to his siblings. Hector was overwhelmed with his multiple part-time jobs. It was pretty hectic trying to work in New York, trying to work in Puerto Rico, going back and forth. Unfortunately, he struggled in terms of being financially stable. The kinds of jobs that he had were in the service industry. He didn't make a sort of high salary. He had a sort of minimal sort of compensation. If I remember correctly, he didn't have really good health insurance. He was underinsured. And so he started to resort to alcohol use. And at some point, he transitioned from using marijuana and from sniffing cocaine to actually injecting heroin. And, initially, he was sort of sniffing heroin, but he then progressed to actual heroin injection. He said that he did drugs to feel better, that they made him reduce his stress, and that he felt at times sort of happier, took the edge off. At the age of 22, he came out to his parents as being gay, and so Hector also was grappling not only with sort of financially having a hard time, also dealing with issues of alcohol, injection, drug use. He was struggling with his identity as being sort of a person who is gay. He told his parents, and unfortunately, because of traditional sort of religious beliefs, his family was not very accepting. And so parental acceptance is really important for sexual minorities, for people who identify as homosexual or gay or bi, or people who have gender identity conflicts in terms of their biological sex and also their identity of who they see themselves as being. That really family acceptance is quite important, and that it's one of the ways in which we can reduce unnecessary distress and negative outcomes among people who may be struggling with these issues. He became estranged from his family. Remember familismo and the importance of the family as a primary reference, source of support, the importance of collectivism versus being on your own. Hector was now on his own. At the age of 25, he got into a fight at a bar in New York City, and he was arrested. He was diagnosed with HIV, and so we'll say that he was at Rikers Island here in New York City. And at the time of his incarceration on Rikers, his CD4 count was below 200. We know that for individuals who have a CD4 count below 200, that this represents an AIDS-defining condition, and that they're much more vulnerable to opportunistic infections, and that's when we want to be thinking about prophylaxis and starting him on something like Bactrim to prevent PCP, to prevent other kinds of infections that would be uncommon among people that have CD4 counts above 200. His viral load was over 50,000 copies, and so that's an elevated viremia. We know that over 1,000 copies that he's able to replicate the virus, and there's actual viral replication that's occurring at a pretty fast rate. And so it means that Hector is able to transmit to others. He's also experiencing chronic inflammation, and that chronic inflammation is potentially sort of wreaking havoc in terms of his immune system activation. And also, we know that chronic inflammation has been tied to a whole range of comorbidities in terms of cardiovascular events, diabetes, elevated blood pressure, all sorts of things that could be controlled if Hector was virally suppressed. He feels stigmatized by his healthcare providers due to his sexual orientation and his cultural background. And so, again, we see that Hector is feeling like his healthcare providers are not very accepting of him as a gay Latino man, of his background, which, the sort of reference to cultural background probably includes his being of Puerto Rican origin, but it also includes him having an incarceration history. And I think if I reflect out loud on many providers when they think about their patients or clients having been incarcerated, there is an almost automatic assumption in many cases, not all, but many, that these are folks that have done something wrong, they've broken the law, they're criminals. There's a kind of negative prototype. There's a negative sort of view of these individuals as somehow being undeserving. And so because of his background, he feels that his providers, don't like him. He feels stigmatized. And when undergoing his treatment, when engaging in care, Hector often asks his providers, am I sick or not? He doesn't feel sick. He says, I'm doing okay, but his CD4 is below 200 and his viral load is actually quite high. His doctors find him to be non-adherent. They say he's not compliant, that he's not adherent, that he's a problem person. He doesn't understand, why, Hector is going to Puerto Rico. Why doesn't he continue with his care? He goes back and forth. He's not an ideal patient, and his clinical team is feeling frustrated. They don't see him as being cooperative. They don't see him as engaging in care. They're viewing him negatively. They don't like his criminal justice background, and they're concerned. They're concerned about his sort of declining CD4 counts as well as his elevated viremia, both from a point of view of morbidity and mortality for Hector, but also in terms of the public health implications of transmission being more likely when people have sort of that level of virus circulating in their blood serum. And so Hector is ashamed of his HIV status. He starts to become socially isolated or reclusive. He's got a lot of denial. He doesn't feel like he has HIV. He doesn't want people to know that he's HIV positive. He doesn't know when, how, or whom he became infected by. And so he's really struggling with some basic questions about his HIV status. He started questioning how HIV was going to affect his life. He feared that he wasn't going to be able to go back and forth to Puerto Rico. He wasn't going to be able to work. It was going to really, impact his financial stability. He wonders about romantic relationships. Will he be able to date anyone? He's feeling socially isolated because he doesn't want people to know about his diagnosis. He feels stigma. He's not getting adequate support from his providers. He feels alone. He doesn't have that sort of collectivism. He feels very much on his own, and he becomes depressed. Hector's now diagnosed with depression. At the time of his diagnosis, he says, hey, are you saying that I'm crazy? Are you saying that there's something wrong with me? He becomes more reclusive. He starts to avoid family and friends. And you can imagine that Hector is probably having a harder time in terms of his engagement in care, his use of alcohol, his use of heroin and other injection drugs. Hector wasn't familiar with HIV or depression, and he didn't have a lot of information about what a 50,000 viral load meant, what a CD4 count below 200 means, and he feels like he's okay, and he's not crazy. And he is wondering, what's the problem? And he's afraid to ask questions, his providers already feel, he feels that they stigmatize him, and he doesn't think there'll be any positive outcomes, and he doesn't want to be dropped completely from his care. So I want to take that case. That sounds like a pretty familiar case to me of people that I've seen in my own practice, and hopefully the case resonates with you, some of the issues that I try to describe. And so I'm going to very quickly go through our 4 frameworks. The idea is not to use all 4 frameworks with Hector, but really to think about how aspects of each of these frameworks could help to improve cultural competence, and how that cultural competence in turn could help Hector to have a better outcome, and that Hector could in fact be more engaged, more retained, and actually achieve viral suppression and overall health and well-being can be improved by adopting some of these strategies. So let's start with the cultural formulation. So step 1 is the cultural identity. So let's ask, what is Hector's cultural identity? He says that he's Puerto Rican, he identifies as Puerto Rican, so that's really important. He identifies as gay. He identifies as somebody who has a criminal justice background. He also is someone who has a history of substance abuse or substance use. He's involved with both Puerto Rican and also border-dominant U.S. culture. He's bilingual, fluent in English and Spanish. He has no preferences, and he's able to communicate effectively in both. Are there other things that you can think of that might help to shape Hector's identity? He might see himself, for example, as somebody who is without a family. That may be something that's particularly important to him, that he's lost because of what he feels is the estrangement from his parents because of him being gay. Step number 2, cultural explanations of the illness. And so again, we want to think, how does Hector understand the meaning, the severity? How does he sort of think about sort of the causes and explanations that explain how he got into the situation he's in, or what have his experiences been with the healthcare system? And so again, I think really prominent in the case is this idea that Hector feels that his providers are stigmatizing him. They don't accept him for who he is, whether it be gay or having a history of criminal justice involvement, or even sort of more frequently, someone who's actively using substances. I think again, that often is difficult for many providers, someone who's actively using alcohol, actively using injection drugs, and so those tend to be things that sometimes patient or client can feel stigma. He doesn't know who or how or when he became HIV positive. He's raising sort of basic questions about that, and the case study suggests that he has some denial, and that denial is not allowing him to completely understand the severity of low CD4 count, high viremia. He doesn't completely understand the implications of depression coupled with injection drug use and alcohol abuse, and how that could play out in terms of his health and well-being, and sort of harm in terms of morbidity and mortality as relates to HIV. Are there factors in the cultural environment, in the psychosocial environment, that could be impacting the case? And so, Hector has a number of social stressors, right? He doesn't have all the supports that he needs in terms of family. He's struggling in terms of income and having a job. He, is struggling with the local environment because he goes back and forth between Puerto Rico and New York. And so in terms of establishing roots, any kind of steady employment, any kind of real supports in both of those places, it's difficult when you're going back and forth between those places. He does receive some emotional support from siblings, from his sister when he's in Puerto Rico. He's providing some financial support for her, but she's in Puerto Rico. He's half of the time in New York. He also is grappling, I believe, with, I mentioned this already, with depression. He's socially isolated. He doesn't have a lot of contact with friends or other supports. And so he's got a long period of time where he hasn't spoken to people that potentially could help him. So the patient-provider relationship. And so what are some of the individual differences that are operating? And then how can these differences cause sort of distortions in diagnosis and treatment? And so one big distortion that jumps out is that his clinical care team thinks that he is not adherent, that he's sort of a problem patient that's not sort of adhering to his treatment. And it may very well be the case that he's not, but I think if we examine this from a cultural lens, in particular transnationalism, he is spending 6 months out of the year in Puerto Rico, and he's spending 6 months out of the year in New York. It might make sense to actually think about having sort of linkage to providers in Puerto Rico, where there's sort of planned times when he's going to have care in New York and planned times when he's going to have care in Puerto Rico. There's also differences in socioeconomic status, where, in Hector's case, he, may feel a certain deference or respect for his medical providers. He may want to preserve harmony, not create conflict. He may use more indirect language versus direct. They're all those things that we talked about early on in webinar 1. They all are sort of important aspects that can fit into this part of the patient-provider relationship. The step 5 is, how do you pull together all of the sort of cultural considerations that we covered in step 1 through 4, and how do we sort of come up with a treatment plan that will address some of those barriers and promote opportunities for linkage to care. So we've mentioned the linkage to services both in New York and Puerto Rico that should be arranged and formally connected, decreasing his social isolation and getting him sort of mobilized in terms of his family or other sort of peer networks that will be supportive. I think, providing him with some support services and some patient navigation, assistance in terms of employment. I think also reframing adherence from a transnationalism perspective, okay? And so let's look at the transnational profile. And so again, if we asked him some pretty straightforward questions, how often does he plan to travel to Puerto Rico? What does he like about traveling to Puerto Rico? I think that might provide some perspective on how we can best support him. Where does Hector's family live? Is he in contact with his family members? Again, important for his social support. Does Hector send or receive money? He is sending money to his siblings, and so that provides a hardship or a potential hardship for somebody who's not making enough money, that in addition he's sending money to his siblings. That must be particularly hard on him in New York City. How does he identify, and would he rather live in the continental U.S. or in Puerto Rico? And if so, how come? Okay, I'm going to advance this, and I'm going to go to the DECIDE model. So DECIDE was our way to encourage activation and increase self-management for patients. How does Hector describe the problem? Well, it's not clear to me that Hector sees this as a problem, or he may see the problem as being his providers, or stigmatizing him, which again can totally be valuable and valid, but I wouldn't say that the problem is solely that. I think the problem is his antiretrovirals, his broader treatment, and how to get him back into care. Right? We want to explore questions with Hector. What would you actually ask him to better understand his circumstance? How does travel fit into his life? How does being in Puerto Rico help him to cope and to manage? You want to look to see what open-ended or closed-ended questions Hector is asking. That's going to provide insights in terms of his priorities and what he sees as being really relevant. Identify the who, the why, the how of the problem, address all aspects, provide direct and indirect questions, and help Hector to think about what a potential solution is and how jointly you can identify options that he can then sort of execute. So this last part of our case study is really looking at shared decision-making and applying it to the other 3 components that we've just completed. So we just did the DECIDE model, and so we want to try to encourage, through DECIDE, more involvement in sort of shared decision-making process. And so this is the perfect time to think about Hector and to cover our 6 steps and to talk about how shared decision-making could help Hector to come up with a plan, and how we as providers can support Hector to have sort of a culturally appropriate and competent sort of shared decision plan for better management of his HIV disease. And so first we want to invite Hector to participate. We want to let him know that he has a role, that there are options, that there are things that he can decide. It's not just one way, but the truth is he may decide that he wants to have all of his care in New York. He may want to have all of his care in Puerto Rico. He may want to have it in both places. And if that's the case, then it's okay to try to think about linking him to clinics both in New York and also in Puerto Rico. We want to present the options and make sure that we give Hector all the options, that they be evidence-based, best practice, free of bias, and that he understands that he has choices that are based on his preferences, his values, and that those options are for him to deliberate, and that for us, our job is to provide the necessary information on the benefits and the risk of all the different options that Hector has available to him. We want Hector to understand how to evaluate the options and how those options are consistent with his own goals and what he prioritizes and what he sees as a concern and what he thinks will be sort of the important outcomes of his treatment, what he values most. We're going to facilitate that deliberation and help him to make a decision. Ask Hector, what do you need to feel comfortable in making a decision? How can we talk about, any of the things that he's presented, whether it be issues regarding his low CD4 count, his viremia, his depression, his social isolation, his alcohol and drug use, his lack of employment, his stigma. Any of those things can be sort of laid out in terms of important areas for him to prioritize. And once he's identified his goals, what his concerns are, help facilitate the process of deliberation. Hector, what would you like to work on first? What makes most sense? I want to provide you with some perspective on what I see as being most pressing, but I want to make sure that I'm offering you the opportunity to think of all the options, that you're fully participating, and that you can sort of decide what it is that makes most sense for you. And then the last one we want to talk about in terms of shared decision making is really assisting with implementation. How do we help Hector now that he's identified a plan and we've gone to a place where he's made a decision that we jointly have come to agree on, to really implement the plan in a way that he can be successful? And so as providers, what do we need to do? Do we need to actually accompany him to his first behavioral health appointment? Do we need to try to actually identify a clinic for him in Puerto Rico that is close to where he's going to be staying there and have a formal agreement? Do you want to set up consents or release of information so that the providers can sort of communicate freely for better care coordination? We want to just do whatever we can to really help Hector to have success in terms of implementing his plan. I want to wrap up by saying that we've covered our 4 conceptual frameworks, the cultural formulation, transnationalism, decide and share decision making. And I want to bring us back to where we started. We started saying that HIV/AIDS is a national priority. It's important for Latinos in our country as well as individuals with a criminal justice background. I hope that as part of our 2 webinars that you've come to understand the interrelated epidemics of HIV/AIDS and incarceration, and you also have a greater appreciation of what's happening among Latino communities, in particular Puerto Ricans, and how the frameworks that we've discussed can apply to real cases in ways that will enhance cultural competence, will increase treatment adherence, have your clients or patients report higher levels of satisfaction, and also we all want to see an overall improvement in health behaviors and in some of the clinical outcomes that we're deeply committed to. Thank you very much. It's been a pleasure. Again, I'm Vincent Kiama Ramos, and you have my email on the screen, and I hope that you've gotten something out of both of our webinars and the series. Thank you.